So something that's important to keep in mind as we're talking about nutrition is that it is largely prioritized and managed by nurses. So assessing OG, NG, G-tube, J-tube, efficiency, function, administering feeds, administering medications. These are all largely led by nursing and nurses. So Table 3911 has a really good table that goes into an overview of the role of the nurse in administration of enteral nutrition. Some important things to keep in mind are that the head of the bed should be at least 30 degrees so that we're decreasing the risk of aspiration while we're administering feeds. If the patient can't be elevated 30 degrees due to some kind of trauma to the back or the neck, then reverse Trendelenburg at the minimum, or they may just be a patient that's requiring a J-tube placement that goes below the stomach to decrease that risk of aspiration. And then another thing to keep in mind is, although we often insert OG and NG tubes by, measuring it from the nose to the ear to the xiphoid process, that's how you measure a tube, nose to ear to xiphoid process, or mouth to ear to xiphoid process. You measure, then you insert the tube. And a lot of times you'll see people inject 30 cc's of air and you hear the little gurgling in the stomach to know that you're there. That's a great initial step to know that you've put the tube in the right place. But before you use a tube, you have to confirm placement with x-ray. So that auscultation is not an official way to confirm tube placement. Other ways you can check tube placement is by aspirating some gastric fluid and then checking the pH on a pH strip to see if you're in the right place, which is great, but also that initial insertion has to be confirmed with placement, with x-ray, Lord have mercy, excuse me. So this picture just kind of shows what we were talking about, a nasogastric tube inserted through the nose and goes down to the stomach. There's nasoduodenal tube, so I bet you can guess that goes from the nose to the duodenum. A nasojejunal tube, nose to the jejunum. A J-tube or a jejunostomy tube is right outside the small intestine here, so it goes out through an opening in the abdominal cavity. And then a G-tube or a gastrostomy tube, which would go out on the surface of the abdominal cavity in the location of the stomach. We're also going to talk about TPN or total parenteral nutrition, as well as PPN or peripheral parenteral nutrition. We're going to get there, so don't worry about that right now. I'll tell you exactly what that is. So back to enteral nutrition. Again, who needs it? These are those people who have relatively long-term nutritional needs that can't be met orally. Lots of different patients meet this criteria. Patients in the ICU that are intubated, patients who have difficulty swallowing related to a brain tumor, head injury, stroke patients. Sometimes palliative care patients need this. Dementia patients may need this, etc. Who can insert these? Well, those small bore tubes can be inserted by an RN. And when I say small bore tubes, I'm talking about the NG tube, the OG tubes, things like that. If they are going to be inserted into the small intestine, that does usually require special training. So a nurse can do it, but it's usually more training than what nursing school provides. And then G or J tubes are inserted surgically, so they are performed by a physician or a similar position, a nurse practitioner or a physician's assistant who has been trained to do it. And then again, how is placement confirmed? Initially, always via an x-ray. Chest x-ray to rule out that it's in the lungs, and a KUB, a kidney, ureter, and bladder x-ray to ensure that it does end where it's supposed to end, whether that's the stomach or the intestines, etc. And then if we were to aspirate contents to check the pH, if you got a pH result of 1 to 4, that would be stomach contents, stomach acid. So that makes sense because the contents that would be in the stomach are very acidic. And then if the pH comes back greater than 6, then we're in the intestines. If you're supposed to be in the stomach, and you get a greater than 6 pH, then it probably needs to be pulled back a little bit because it's gone too far. If you need to be in the intestines and you get a value of 1 to 4, then you probably need to insert the tube further to get it down into the intestines. Here is kind of a picture view of our tubes. This is a small bore feeding tube. They're usually yellow. They're very, very flexible and flimsy. And they actually have a guide wire in them to be able to insert them, to give them strength to be inserted without like coiling up. And then you take the x-ray, that guide wire allows you to visualize the x-ray, confirm the placement, and then you can take that guide wire out. The picture on the right, the clear tube, is a decompression tube. We insert those in patients who have like a small bowel obstruction, who are either going to have surgery or who are just going to try conservative management to rest their bowel. And so the purpose of this is to insert it either OG or NG, and then hook the end up to low wall suction so that we're getting rid of all the gastric acids that are in the stomach. That helps decrease nausea, decrease vomiting, and helps rest the GI tract. These are also initially inserted in patients who come in for and get intubated. So if they go to the ICU, it's part of a way to prevent aspiration while they're intubated. And these tubes can be like, if we're not going to decompress anymore, if we're not going to have them hooked up to suction, then we can actually start feeds through them. So both of these tubes can be used for feeding. However, this yellow small bore tube cannot be used for suction. It is so flimsy and so narrow that it would not be able to withstand suction like this tube can on the right. So again, both can be used for feeding, only one can be used for decompression. Looking at G tubes or J tubes, they are an invasive procedure, a surgical procedure that requires informed consent to be obtained. We do need to have coags at a baseline to assess their risk of bleeding post-operatively. Patient needs to be NPO at midnight, and if they are receiving feeds via a G tube, like an OG or an NG tube, then those tubes need to be stopped so their stomach will be empty in the morning. IV antibiotics to prophylactically prevent infection. And then we can provide local anesthetic for the abdominal puncture, so lidocaine type medications. And it's a pretty quick and easy procedure, just takes about 30 to 45 minutes. So again, a lot of times these are done at bedside with endoscopy staff and radiologists to help confirm placement and guide as the tube is being inserted. These are done very frequently, and it's a pretty low risk procedure. Enteral nutrition can be administered in a couple different ways. There is a continuous way, which is utilizing this infusion pump on the right, and feeds are infused over 24 hours at a rate anywhere between 50 and 150 mLs per hour. The intermittent or bolus feeding doesn't utilize the pump. We just, inject a episode of, what am I trying to say? We just inject a bolus of feed with a pump I just contradicted myself. A pump can be used to bolus one feed in. Although what's more common to do is use a syringe and just administer the feed, or hang it on the pole and allow gravity to let it go in. But it is not continuous. That's the point. It is intermittent. It's bolused in a few times a day. What do you think is more optimal for the patient? Like, what's our goal for the patient? Continuous feeds or intermittent feeds? What do we normally eat as? Do we normally continuously eat over 24 hours a day? No, we do not. We eat 3 to 5 meals a day, depending, on how much we eat or our activity status or whatnot. So our goal for patients is to get them back to the most realistic state possible, which would be intermittent feeds. Sometimes people can't handle that though. That bolus of food can be too much for them to handle. So sometimes that slow, continuous feed is what they need until they can build up to intermittent feeds. Again, please remember aspiration precautions for these patients. The head of bed needs to be up at least 30 degrees. If it can't be up, then a J tube may be indicated. We want to check placement of our tubes every 4 hours. And we can do that by auscultating for pH, for contents and checking the pH. Another way that we can check that is just to look at the centimeters on the tube. So if you go back to this tube, you can see that there's little tick marks and measurements here. So if the patient had the tube inserted at 55 centimeters at the teeth, then we would want to make sure that the tube is still at 55 centimeters every time that we're using it. We can check GRV, or gastric residual volume. We want to do that every 4 hours or before a bolus or intermittent feed. So if the patient has a continuous infusion of feed going on, then we want to check it every 4 hours. If they're getting a bolus or an intermittent feed, then we just want to check it right before we administer that feed. And so what you're going to do is you're going to hook that 60 ml syringe onto the end of the tube and pull back the contents. As we pull that back, the normal would be less than 250. And then what do you do with the contents? You give it back. So you don't throw it away or anything. You check it, you assess the volume, and then you put it back into them. If you get a reading that's greater than 250, but less than 500 on 2 consecutive measurements. So if I went into my patient's room and I pulled back gastric residual volume and I got, for example, 350, I would re-administer that back to them, and then I would come back in an hour and recheck it. If on that second hour I got less than 250, it's no problem. I don't need to call the doctor or anything. It was just a fluke that I had such a large volume the first hour. But if I come back that second hour and it continues to be 350, 400, 300, etc., anything between 250 and 500, then we need to stop the feeds and call the physician. If we have one reading that's greater than 500 mLs, that's too much to be in the stomach. We need to stop the feed and call the physician. Something is happening in the patient that they are not propelling the fluid and the food forward. So we're going to overwhelm them. We need to stop the feed, stop what we're doing, and let the physician know so they can start a medication if need be, so they can assess if there is some kind of obstruction. Maybe they just need a break and we were giving them too much, so they need to digest and process what we've given them, and then we can restart. So lots of different options, but we do, at the bare minimum, need to stop the feeds and call the doctor. We normally don't eat constantly without drinking any fluid. So that same concept is here with flushing with free water. So, and that can just be tap water if you think about it. What we're giving these patients would be going into our GI systems as well, and we don't eat sterile food. So we don't have to give them sterile food. We do, and we drink tap water, so they can also get tap water. So just remember that you want to flush with free water between bolus feeds or every 4 hours if they're receiving a continuous feed. And we really want to prevent a clogged tube. It's incredibly inconvenient for the patient and you as the staff taking care of the patient to have a clogged tube. If that happens, there's some, certain types of fluids and medications that you can give to try to declog the tube. Some places even use like Coca-Cola because the acidity and carbonation can unclog tubes sometimes. If none of that works though, then you're going to have to take the tube out and reinsert it, which is just unfortunate for everyone involved. So keep in mind, if you're giving medications through the tube, you want to make sure they're crushed incredibly well so that you're decreasing the risk of it getting clogged. And then remember, you can't crush certain meds. So what meds can you not crush? Those would be things like your enteric coated, your extended release, your sustained release medications. Those can't be crushed. So keep that in mind. You would have to call the doctor and get it ordered in a different way. If it's in a liquid version, then you would try to get that medication. Otherwise, it can't be crushed and given to them PO. So just keep that in mind. And then if you are giving medications or bolus feeds, remember to flush before and after with free water. Complications of enteral nutrition are diarrhea. So what puts a patient at risk of diarrhea is giving them too much too quickly. So make sure you start slowly. Sterility here shouldn't confuse you. Again, like I said, the foods that we are giving them are not sterile, but in what we are, when we access our tubes, we should make sure we're doing so in a clean way to prevent infection and complications. If we're doing these things correctly and they're still having diarrhea, they may just need a different formula. It might not be what one that the patient's tolerating. So we may just need to switch gears here. Check for impaction. They could have impaction in the rectal vault, so we can digitally decompact them. And they may just need some anti-diarrhea meds. So we can trial all of those things to help prevent diarrhea. Skin protection, you don't want these tubes falling out, so tape them securely to the patient. You wouldn't insert an OG tube on an awake patient. OG tubes are only inserted into patients who don't have gag reflexes, so those who are intubated. If the patient's awake, they would only be a candidate for the NG route. PEG tubes may initially have a drainage sponge. Post-operatively, a lot of people don't use them after they're out of that immediate post-op care. And then you want to monitor for signs of skin breakdown or infection. You can tell skin breakdown, of course, if there's like excoriation to the site around the tape or the tube itself. And then local signs of infection would be redness, warmth, drainage, tenderness to the site. So we would want to be definitely aware of those things and let the doctor know if we notice any of them. And then again, tables 39, 11, and 12 are great summaries of nursing management. I highly encourage you to look at those to help apply some of this information. Parenteral nutrition is administered into the bloodstream. So for whatever reason, the GI tract is not working. We can't utilize it to feed patients, so we're having to administer it directly into the blood. The solutions that we're giving the patients are customized to meet their individualized needs. And solutions contain proteins, carbohydrates in the form of dextrose, fats in the form of lipids, and other electrolytes and vitamins based on their lab results and what their individual needs are. It can be administered through a central line, which is preferred, or can be given peripherally through a PICC line. So parenteral nutrition can't go through a regular IV. It has to go through a peripherally inserted central line. We'll talk more about what those look like in just a second. And then it needs a designated line for infusion. The only thing that can run through these lines is the TPN, nothing else. What might indicate that a patient needs parenteral nutrition? Well, we assess their albumin and prealbumin levels to determine their need. Normal albumin is 3.5 to 5. If an albumin level comes back less than 2.5, that means that the patient needs nutrition. The half-life of albumin is 20 to 24 days. So sometimes this lab can be delayed in telling us that the patient needs nutrition. A better indicator of nutritional status is the prealbumin because it has a shorter half-life of just 2 to 4 days. Normal prealbumin is 17 to 40, and less than 17 needs nutrition. You do need to know these values and what a value requiring nutrition would be. So a PICC line, this is that peripherally inserted central line. That's what it stands for. It's inserted into the superior vena cava, as you can see in this picture. It goes all the way up to the superior vena cava. So it's a very long catheter, but the initial insertion site is peripherally in the arm here. It does require x-ray confirmation to make sure it's in the right place. It's initially sutured in, but those sutures can be removed down the line 7 to 10 days later. And this is for relatively long-term administration needs, things like antibiotics, nutrition, fluids on a chronic basis. It can be inserted by a specially trained RN or a physician, nurse practitioner, PA, but it does require extra training. So that's what you need to know. It can be done in the patient's room or in a radiology suite. They are commonly done in a patient's room though. And most of the time they are initially sutured before they're removed. Again, a PICC line is indicated in patients who need IV administration of meds or fluids for 2 weeks or longer, or if they have poor IV site availability. Long-term needs for IV fluids for chronic dehydration, TPN, chemotherapy, and long-term IV pain management. Those are all indicators of PICC line insertion. A central venous catheter is great. It's used for shorter term use though than what a PICC line can be used. So these can only be used for 3 to 10 days, usually in an acute care setting. It is also inserted into the superior vena cava by an MD or a trained nurse practitioner or physician's assistant. They are usually sutured in place for the entirety of the insertion. There is high-risk complications of infection, so central line bloodstream infections or CLABSI, central line bloodstream infections can occur with this insertion. So making sure the insertion is done sterilely and then changing dressings sterilely, and every time we access it, sorry, I'm at work and I got a message, so excuse me for that pause. So anytime we access it or use it, we want to make sure we're doing so in a clean, sterile way. And then the reason there's a risk for pneumothorax is at this site here in the subclavian area, the apex of the lungs, the tip of the lungs is right there. So there is a risk of the physician nicking the lung and causing a collapsed lung. So remember, we would know that there's a collapsed lung developing if they're in respiratory distress, decreasing SpO2 on the monitor, if they're requiring increased supplemental O2, and if we auscultate that lung and we hear diminished or no breath sounds. Those are high suspicion assessment findings for a pneumothorax. And then I also want to say here that a central venous catheter can be inserted in 3 areas. It can be inserted in the neck through the internal jugular vein, the IJ. It can be inserted into the upper chest in the subclavian vein, or it can be inserted through the femoral vein in the groin. And those catheters all end up going into the vena cava. These are great access points for our patients to have because they have multiple lumens. You can see here that this one has 2. Most have 3. So that's 3 lines that we have access to give medications through. So they're great for when patients are sick and require multiple medications at once. A tunneled venous catheter is very similar to a central line, but it can be used for a longer period of time, where a central line can only be used for 3 to 10 days. This can be used for much longer. It's tunneled into the subcutaneous tissue. You can see here, this is the external catheter. It goes inserted here, and it's tunneled through the subcutaneous tissue until it enters the subclavian vein up here. So it's a much more sturdy, strong line with a lower risk of infection. And the most common area for this to be seen is the subclavian. It can be the femoral vein, although honestly in practice I've never even seen a tunneled femoral venous catheter. I've only seen subclavian tunneled venous catheters. So, and then these sutures are removed in 7 to 14 days. And again, this can be used for months at a time. It's a great access point. Ports are also great. A lot of cancer patients have ports because it's a great access point for chemotherapy. It's typically inserted into the subclavian or internal jugular vein. You can see here it's in a pocket of the subcutaneous tissue in the chest most commonly. And then there is a catheter underneath the skin that gets inserted into the subclavian vein and into the superior vena cava. This is on what it would look like on a patient. So you actually can fill that bulge of the port and you just kind of stabilize it and use sterile technique to insert this port needle and access the catheter. As you do that, it looks like this from a lateral view. So you're inserting this needle and there is a collection of heparinized blood that's sitting in this port that gives you access to the subclavian vein to administer fluids, to draw blood, et cetera, et cetera. When you are taking the needle out, the port stays in place always under the skin, but you take this needle out. Before you do that, you insert a small volume of heparin so that the blood that's sitting stagnant in this port doesn't clot. You don't want the port to clot off. That would mean that it would have to be taken out and replaced. So that's definitely not what we want to see happen. And again, it's the lowest risk of infection of all central access. It's incredibly convenient for the patient. They have a guaranteed access point. I love ports. Again, it's a guarantee for me to have a line access on a patient. And you just literally push that needle through the skin in the center of that port and you're good to go. It's an awesome access. So things to keep in mind here, parenteral nutrition, again, is still largely managed by the nurse. Parenteral nutrition always goes on a pump. You do not bolus it. It has a specific order to run at a specific rate, and you need to check that label against the order to make sure that it's being administered correctly. You should not hang any bag for longer than 24 hours. And the reason is because this nutrition has lots of sugar and fats in it. And that's a breeding ground for bacteria and infections. So the longest any bag or any tubing can be hanging is less than 24 hours. If you are changing the tubing, if you're changing the bag, you can't keep the same tubing. The whole thing has to go. So just keep that in mind. If the patient has to leave the floor for testing or surgery or anything like that, and they don't get their full bag of nutrition in that 24 hours, you don't keep running it. You throw it away. That you don't put them at that risk for infection like that. And then because we're administering dextrose in such a concentrated way, we want to monitor their blood glucose. Even if they're not diabetic, we're monitoring at least every 6 hours, and they may require insulin while they're on that TPN. That doesn't mean that they're diabetic, or if they're a diabetic patient, it doesn't mean it's going to get worse. It's just for that time while they're getting the parenteral nutrition. And then related to central line care, we want to follow that specific facility's protocol in regards to flushing it regularly, changing the dressing and doing so sterilely, etc. And again, nothing goes through the TPN line except for TPN and lipids. So 1 lumen is dedicated to nothing but TPN and lipids. Keep in mind what local infection signs might be around that central line. So that would be things like redness, streaking, warmth, tenderness. If the infection had gone systemic, then we would see things like fever development, tachycardia, hypotension, etc. So here's a few practice questions. What method is best to use when confirming initial placement of a blindly inserted small bore feeding tube? What the blindly means is that you just inserted it. You didn't have like radiology or ultrasound there. That is the normal way to insert a feeding tube. But what is the best way to confirm that? An X-ray, air insertion, observing the patient for coughing, or pH measurement of gastric aspirate. And the best way to confirm initial placement of a tube is X-ray. A patient is receiving peripheral parenteral nutrition. The solution is completed before the next solution arrives on the unit. So again, TPN and peripherally inserted parenteral nutrition run continuously and the bag comes from pharmacy, it's made every day to meet the patient's individual needs. If that solution is completed before that next bag arrives, what should the nurse do? And we didn't specifically talk about this, but that's why I put the question in here so we can talk about it now. I want you to kind of critically think through the A, B, C, and D answer choices. And because we are inserting a continuous concentrated injection of glucose, if we were just to cold turkey cut the patient off, that puts them at risk of hypoglycemia. So while we are waiting on that new bag to arrive on the unit, we want to start a 5% dextrose solution. We actually often keep 5% dextrose in the room, like a liter bag of 5% dextrose. So if something happens, we can just start that at a slow rate to prevent their blood glucose from bottoming out. And that is it for this chapter. If you have any questions related to what we just covered, please feel free to reach out. You can email or text me, as well as next week while we meet in person, you can also ask me any questions in person. I don't mind at all. I want to make sure that you guys understand this properly. So yeah, it was great doing this Zoom for you, and I look forward to seeing you guys next week. Thank you.